So without further ado, that's how it's going to work. And I would like to welcome Dr. Ibrahim Sahin. He is a medical oncologist at the University of Pittsburgh, and he is an expert in colorectal cancer, but especially the KRAS mutation. So as we all know, the KRAS mutation makes treating colorectal cancer a little more difficult. And so he is going to talk to us tonight about ways to target this mutation. Also, he is making sure that he does talk tonight about some new studies and some things that are on the horizon to treat KRAS. So we are so excited to have you here. I know it's 7 o'clock in the evening your time, and we can't be more thankful and grateful. So I'm going to turn it over to you, and I can't wait to hear everything that you have to present.
Thank you. Yes. Thank you for the kind introduction. It's an honor to be here with you guys. And if this can be anyhow productive for any of you, it'll be an honor for me. And thanks again for the opportunity. So yeah, I'm a medical oncologist. And my primary research is colorectal cancer. And hopefully today I will try to really summarize some knowledge about the colorectal cancer with KRAS mutation and its clinical relevance. And hopefully, again, as Betsy mentioned, that we will talk about the therapeutic opportunities that is rapidly evolving right now. So with that, I'll go ahead and get started. So as an official thing, I have to acknowledge my disclosure. So this is my disclosure here. So KRAS mutations are really a common variety of alteration that we see in GI cancers in general, which is why I think GI cancers are biologically highly different than other disease, including lung cancer. And also they are very heterogeneous. Although we call them KRAS mutations, they don't mean they are actually behaving the same. Biologically, they are different. Their locations can be different. As seen here, exon 2 refers a specific location, and within that exon in the DNA, there are codons called 12 and 13. And alteration or changes in this specific location in DNA, where the KRAS gene is located, can create these different mutations. And in the past, we really had not that much knowledge about their diversity and biological relevance. But as the science evolved, we learned about more and more how they are different in terms of frequencies, but also biologically. So as we see in colorectal cancer, unlike lung cancer, where we see KRAS G12C is the leading type of mutation, in colorectal cancer is actually KRAS G12D mutation. In overall, codon 12 mutations are the most common one as well. And exon 2 mutation, which refers again, codon 12 and 13 represent big majority of the mutation that we see in colorectal cancer. And the non-exon 2 mutations are relatively less common in colon. And again, G12C and these Cs, these are all referring the specific amino acid change. And C here refers actually cysteine, which is a specific mutation amino acid that happens to create a different molecular structure in this mutation. But again, this is unfortunately 3%. And the reason I'm saying unfortunately 3%, because we have already FDA labeled drugs for that. But that doesn't mean that we are not working on other drug developments, and there are more to come in addition to G12C inhibitors. And again, these mutations in specific exons, specific codons can impact how they are responsive to activating and inactivating proteins, because there's always proteins that really interact each other in cellular metabolism, where things are trying to be regulated, and this mutation can alter them. And specific mutation can have different impact how they respond to regulatory proteins and their interaction with also with the small molecule inhibitors. Their intrinsic hydrolysis activity, which means how they are turned off automatically, that normally they should, because there is no really continuous activity of this KRAS normal gene, can be impacted by this mutation. And G12C is one of the mutation where the inactivity, autonomous inactivity, is still somewhat preserved, which is why we had chance to develop drugs a lot faster for this mutation compared to other mutation. So although we call all of them KRAS mutation, they are highly different, their names are different, their biology is different, and that it has significant impact how drug development evolves so far. In general, KRAS mutation, unfortunately, also are related to worse prognosis, and is demonstrated in this study that published years ago by Dr. Cromolini and colleagues, showing KRAS mutated colorectal cancer biologically behaves different, and patients with this mutation tend to live, unfortunately, lower expected life than those who doesn't have this KRAS mutation. So therefore, we feel as clinical investigators, physician scientists, there's a huge unmet need for drug development in that space. And I'm very happy to say I think there are just some optimization is needed for faster drug development, particularly for colorectal cancer, which I will touch base later on. So frontline therapy, again, just in general, for everyone to have an idea, it's not really, chemotherapy is not really affected, choice of chemotherapy per se, but it is, it does impact the one therapeutic agent that we use in daily practice is anti-EGFR treatments or EGFR blockade, which are our panitumumab and cetuximab. And this KRAS mutation, unfortunately, render resistance. So when the tumor has this mutation in it, then we know the anti-EGFR, which is the panitumumab and cetuximab, doesn't work very well. And I think certainly depending on patient preference, could consider triplet regimen or doublet regimen. This is more an discussion rather than true one better than other in terms of efficacy. I would say there is slight improvement overall survival with the triplet regimen, which is FOLFOXIRI, but really there is also toxicity comes with three-drug regimen. Therefore, I feel it is oftentimes an informed decision around risk and benefits, and it should be individualized rather than should be one fit for everyone. Again, for patient with G12C mutation, now we have approved drugs, so that's very exciting. Not all KRAS mutation for G12C, and they are already one of them given accelerated approval, which is adagrasib cetuximab based on single-arm study where response rate was highly promising, and the other was randomized trial, which is sotorasib and panitumumab. And these were all colorectal cancer patient studies, unlike the other studies I will be chatting on later on, where our early phase drug development are happening. These were all colorectal cancer patients. Benefit was solid enough for FDA to give drug approval. And these were chemotherapy refractory settings. And here's some of the results, which there are some key information here I think may be somehow relevant for our industry colleagues to learn from the studies. So in this trial where adagrasib and cetuximab has been investigated, the objective response rate was 46%, which is referred to partial response. And it was only 19% when it was given as a monotherapy. So it is more than twice the response rate when we combine with anti-EGFR with KRAS G12C inhibitors. This is very important because I think this is oftentimes seen in sometimes in real practice, I've seen in real practice, but also in drug development. The randomized trial of sotorasib panitumumab, and when sotorasib being developed, this went through also again, sotorasib monotherapy, the efficacy was very minimal when it's used alone without panitumumab. But with the combination of panitumumab, it did result in a lot more significant response, and which led this randomized trial. And in this randomized trial, obviously, the response rate was 24%, much better than monotherapy that we've seen, which was around 9% to 10%. And the duration of response, median PFS, was a lot better than what we have in our as a third-line regimens. So that resulted in approval of this regimen in chemorefractory setting. And both of these agents are currently being investigated in combination with chemotherapy in frontline. Some of them are looking for early safety data, and there's another molecule which is called divarasib. I think I included that as well, which I will talk. And they are also looking for safety when it's combined, when they are combined, how safe they are in terms of tolerability. So a few interesting things that I thought it's important, and I presented this actually in the also another talk. I'm hoping this will turn out to be proven in other studies as well, because liver metastasis of colon cancer is biologically more challenging than the lung metastasis. And I'm sure there were talks in the past how immunotherapy has some effect in those with lung metastasis without the liver. And liver metastasis where the challenges are. And this study, the combination of sotorasib and panitumumab had more favorable outcomes to those patients with liver metastasis. So hopefully, maybe the precision medicine therapeutics will help us more effective treatments for those patients with active liver metastasis. So this was a post-hoc analysis, and I'm really looking forward to see how this is being played out in other studies in the future when we have those randomized trials in other molecules as well. What other options aside the G12C inhibitors, which we'll be talking a little later on, there are trials. We classify them in general as concept in two groups. One is allele-specific inhibitors. Allele means, and when you guys hear if someone comes, oh, we have allele-specific KRAS inhibitor, that means there is a molecule, an agent that specifically inhibits a specific KRAS mutation, which can be referred as G12D, G13D, or obviously there are NRAS mutation we see in colon cancer as well, and 61 codon 61 mutations are the most common one. So all these specific mutations are referred as allele, and then molecules that specifically inhibits those specific mutations are called allele-specific inhibitors. Pan-KRAS inhibitors, in definition, inhibits everything about the KRAS, which means KRAS mutations that can happen in any codon or exon, or even the KRAS wild type. Wild type KRAS means that is normally there are two copies of each single gene in our bodies, and one is mutated, the other can be normally expressed, and these molecules inhibits both of them. Each copies of the proteins in our body, even if there is KRAS. And I think they are relevant because, which I will touch base later on, some of the resistance may be developing because of RAS wild type being amplified. Now, so the KRAS, pan-KRAS refers supposedly that all KRAS mutations are being inhibited, and also the KRAS wild type by definition. That being said, some pan-KRAS inhibitors that I've seen and in trials are not inhibiting all KRAS mutation. They are just more, not allele specific, rather more inhibiting most of the KRAS mutation, but missing some of them. So it is important to really make sure that specific KRAS mutation is included in the trial when you guys are looking for a trial and also talking with the oncologist. Pan-RAS is even more comprehensive. In addition to the KRAS, we have a oncogene in our body that can turn into oncogene, which is called NRAS. And NRAS is also a molecular alteration we see in colon cancer up to 4 to 8%. And pan-RAS inhibitor inhibits the NRAS in addition to the KRAS. So they are even more comprehensive. And they also inhibit anything about NRAS, including wild type NRAS, which is normal NRAS. And they inhibit also HRAS, which is somewhat less relevant because we don't see a lot of HRAS mutations. So anyhow, so the pan-RAS in general means it's even more comprehensively inhibiting everything about RAS. That doesn't mean always it is better, because we don't still have that answer, and I'll touch base later on why, whether inhibiting everything about RAS or KRAS is the way to go as opposed to the specific inhibitors. Important again, I think I'm trying to emphasize with industry whenever I work with them, whenever I go there at boards, that EGFR blockade should be implemented early in the course, just because as I mentioned earlier, that without the EGFR blockade, especially for allele-specific inhibitors, the efficacy really gets limited, becomes limited. And the main reason for that, because of the specific molecular characteristic of colon cancer. We learned over the decades, not specific for KRAS, but also same for the BRAF. If we did not block the EGFR, the inhibition of KRAS or the BRAF, increase the activity of that receptor, which creates a bypass, which is why what we see in colon cancer is very different than in lung cancer and even the pancreatic. So those agents oftentimes work okay in pancreatic cancer and lung cancer as a monotherapies, but their efficacy is always challenged as a monotherapy in colon cancer. And we learned that on this two drug development, sotorasib and adagrasib, but also BRAF inhibition and corafenib, which of some of these BRAF inhibitors tested as a monotherapies, even in combination with chemotherapy with limited activity, up until they are combined with EGFR blockade. So this is a recent meeting results, which is pretty impressive, and happy to see this. It's not in colon cancer yet. So it is this agent, which is Revolution Medicine molecule, which the other name was RMC 9805, and now new name is zoldonrasib. They have now a name, and they tested in different solid tumors, and now they presented in the lung cancer, and the response rate was 61%. We don't have the colon cancer data yet, but I'm hoping from previous experiences that whatever is found in other disease eventually will come to colon cancer. The caveat I've seen again with RMC and maybe probably other industry groups as well, that again during the dose escalation, whenever they see the signal is the most, then they go that area first. We have seen that in the story with the G12C inhibitor as well, which is why we were behind in drug development in colon cancer as compared to lung cancer. And I'm trying to emphasize this again and again at multiple platforms. And I think the same thing happened here. And obviously, as a monotherapy, the activity was more promising in the lung. And now they presented in the AACR 2025. This molecule has really potentials for the future for KRAS G12D. And KRAS G12D is the most common KRAS mutation we see in colorectal cancer. So as you guys see, the title is allele-specific versus pan-KRAS. And the reason I shared that, and I put the question mark in previous, but soon I forgot this one, because I just wanted to create an early question for everyone, including myself, but also for drug development purpose. So in this study, unlike the other one, a drug called RMC-6036, which is daraxonrasib, so the same company, but this is a pan-RAS inhibitor. So it inhibits everything about the RAS oncogene. The previous drug here, which is a specific inhibitor, which is KRAS G12D. So in this study, response rate was 61%, versus in this study, response rate was 38%. Obviously, the similar patient population, non-small cell lung cancer in both studies, and which obviously creates a question to us as an investigator. Although pan-RAS inhibitors may be working, but maybe the specific allele inhibitors may have more potency. So I can't say that this is true yet. Obviously, when you see the distinct outcomes, this creates a question in our minds for future drug development. But this was something interesting that I felt important to really put out as a potential question. Nonetheless, this also showed activity. All these bars reflecting how much tumor was shrinking. And here, obviously, every patient experienced tumor shrinkage, but there were 60% of the patient experienced more than 30% shrinkage. Here, it was 38% of the patient experienced 30% or more tumor shrinkage. So overall, I think both are promising, and some more promising signal as of now with allele-specific inhibitors. But with time is going to tell, and we'll learn more. And again, this was also some similar observation of mine that I seen in pancreatic cancer as well. So this is the, again, same molecule, RMC 6236, the pan-RAS inhibitor. So not allele specific, but inhibits everything about KRAS. And in this study that they presented now, this was, sorry, ASCO presentation, and object response rate 29%. And this is obviously great. It's promising because in pancreatic cancer, it's a very challenging disease. But what we learned with the other G12C inhibitor molecules, the response rate were a lot more than 30%. We've seen up to 50% response rates with the specific G12C inhibitors. So that again creates the question, although pan-RAS or pan-KRAS activity may be more appealing because it's broader coverage, it's inhibiting multiple alleles that may exist, which we see, which I'll discuss a little later. But whether that's more effective, I don't know that answer yet, and maybe time's gonna tell. So there were another interesting study, I think these studies are relevant, maybe not directly related to right now to the practice, but future of the practice, learning what resistant mechanisms while these drugs are being developed. And again, as I mentioned earlier, the KRAS amplification, which means that we have again 2 KRAS copies in our body. One gets mutation in one of them is enough for potential oncogenic activity. And the other one, which we call oftentimes wild type, can get amplified. And we called KRAS amplification in wild type gene can cause resistance. And we see receptor tyrosine kinase, which are basically the EGFR receptors, sometimes MET, which is another receptor that has oncogenic activity in itself, can increase the chance of resistance. Interestingly, RAS and RAF mutations, and I personally seen it. I had 2 patients who were on trial in a specific, so I shouldn't say much about the trial. And the patient were getting G12C molecules, and they had great response, thanks to God. But then eventually, when we seen resistance, we performed molecular profiling, and one of my patients had concurrent another KRAS mutation in addition to KRAS G12C. So there are some other reports also, BRAF mutations happening, or any RAF mutations that has oncogenic activity can create resistance. And in one of my patients, interestingly, I seen HER2 amplification as a resistance mechanism after progression. So interesting knowledge coming. These are important because these are also for us to learn for future drug development. Knowing resistant mechanisms can give us more opportunity to do better in the future. And obviously, again, as I mentioned earlier, one thing that came up during our experiences with the BRAF and also the KRAS inhibitors, monotherapies hasn't been so successful. And RMC 9805, which is the Revolution Medicine agent, now has a name, has been investigated and looked, and again, not surprisingly, the more data is coming for lung and pancreatic, and mainly because the initial studies, animal models, these are original study back in earliest published in 2023, that showed the animal models had more signal in pancreatic and lung cancer as compared to the colon cancer, where monotherapy was less promising, which I think was also led to what we are seeing now. The drug development has focused on pancreatic and lung cancer by Revolution Medicine, which I believe mainly driven by this process again, because of monotherapies are not working, and I think it's so crucial for the industry to recognize and that we need to implement anti-EGFR early in the course of therapy, or drug development, I should say. And another one, so this is a study of Astellas, which was presented just last year, called molecule ASB3082. It's a KRAS degradator. It doesn't inhibit specifically the molecule, but it degrades. So kind of remove the molecule from cellular level. It degrades and results in dissolvement of the oncoprotein. And as we see here, pancreatic cancer activity was pretty promising. 3 out of 7 patients had response, which was the most promising response after lung, and one colorectal cancer patient that studied in response. And all in all, the recommended dose, which was 300 milligram in this study, will focus on pancreatic cancer just because of early signals. Anyhow, so these are the challenges, and I think we need to really change our approach for patients with colorectal cancer for drug development. And I think there's really unmet need for more emphasis for how colon cancer patients should be treated in trials differently than those other tumors. Other patients with other tumors, including lung and pancreatic cancer. And I think time is going to hopefully help us to really change this practice. Anyhow, moving on for other approaches beyond the EGFR and KRAS together, there are hope maybe that maybe KRAS inhibitors can be combined with immunotherapy. This was another interesting thing I found in AACR. I couldn't make it, but this is one of the things that I felt interesting from virtual search, that inhibition of KRAS may actually give us opportunity to use immunotherapy for MSS colorectal cancer. And this was always a question in my mind, and I'm so happy to see this in animal models. So these are very early phase animal models that seems to be holding a promise. In this study, investigator combined KRAS G12C inhibitors with anti-PD-1, which are immune checkpoint inhibitors, and they seen activity of the T cells with anti-tumor response, and that results in a reduction in tumor volume as compared to monotherapies. Maybe in the future, immunotherapy with G12C inhibitor for colon cancer may have hope. These are combined in lung cancer patients, and we've seen some good responses. Some had challenges due to toxicity, but I'm hoping similar approaches will eventually come in to colon cancer. And again, at that point, even with the immune checkpoint inhibitors, we still need EGFR blockade. I want to emphasize that again for hopefully for the industry to understand that our patients are different than other patients with other solid tumors. And there was another study with peptide vaccines. So we are trying to also understand our new hope, especially in pancreatic cancer, maybe KRAS specific peptides and mRNA vaccines can trigger response. And this study try utilizing a peptide vaccine, not mRNA, and combine with nivolumab, ipilimumab. The response rate was modest. It's not as what I would love to see. It was 8%. Generally, for us as a clinical investigator, we would like to see that above 15%. Nonetheless, I think this shouldn't stop us looking for more and more. And one failure doesn't mean the other molecules or our other vaccines not going to work in the future. So these are some other molecules in the field. I didn't put everything here because there are so many of them with different tumors and the different studies, different levels. I just want to give key summaries here and where things are in terms of the drug development. But very good news that we have these different molecules that are in development, and very happy to see industry is putting a lot of effort for KRAS inhibitors, and I'm hoping this will revolutionize the care that we can offer our patients in the future, so that we can change really the practice and also the outcomes of patients. And again, there are allo-specific inhibitors here as summarized, including Mirati drug, Lilly drug, AZ drug, and also Revolution Medicine, obviously. Lilly has a pan-KRAS inhibitor that is in development right now. We are actively trying to open the study in our site. There's pan-RAS inhibitor, RMC, which is 6236, which they opted to pancreatic cancer, which I suspect because, again, drug development favored other solid tumors over colon cancer. And there is some other molecules also in development. And as I mentioned, some try to go over multiple times. I'm hoping we can change our trial designs and how we can implement EGFR blockade at maybe even at dose escalation phase for a patient with colorectal cancer. With that, I think these are my presentation. Thank you.
Thank you so much. I know that we have some questions in the chat. I'm going to do my best to pronounce this stuff. Just remember, I'm not a medical professional, just a patient advocate. So one of the questions that we have is how effective the adagrasib is for patients that are MSS.
Yes, so I'm able to see them too. So you did great on pronunciation, I can tell it. So yeah, adagrasib is effective and is approved, and there is accelerated approval. And patients who were treated were predominantly, I don't think there was a patient with MSI high, so they are highly effective for MSS. I think, to my recollection, all patients enrolled in that study were MSS. So yes, answer is they are effective. The question whether adagrasib versus sotorasib, we don't have head-to-head comparison. That being said, looking to response rate, it was somewhat more favorable for adagrasib cetuximab combination. Nonetheless, we won't have the clear answer whether one is better than other, unless we have a randomized trial. We won't have that answer. It will be more about discussing the side effects of each drug and also understanding head-to-head comparisons of this trial can carry challenges due to difference in inclusion-exclusion criteria sometimes we see, and that may impact the patient population. But short answer to that question, yes. Very happy to say it's for patient with MSS colorectal cancer.
Great. The second question is, can you use NGS or ctDNA to track resistance to KRAS targeted trials?
Good. So they are using ctDNA, collecting samples. They're not reporting those right away. They are generally very eager to just get the initial efficacy data and also the toxicity. But I know they are also collecting actively research labs. And I'm pretty sure they will be looking for resistant mechanisms in those studies, and they will come later on. Yes. In daily practice, it can be used in terms of resistance, which I did as a research question. I was talking to patients where I felt at the time of progression, I I I didn't have a great explanation why the disease is progressing, and we discussed and agreed on doing liquid biopsy, and we did, and we had our answer. So it can be done at the time of progression. And I know some of colleagues are using the ctDNA to understand not specific KRAS amount in the blood, rather ctDNA overall, which circulating tumor, such as a surrogate of response. But in general, this is a surrogate rather than a definitive answer, and we don't use ctDNA to make big decisions in terms of stopping or changing the treatment until we have clear evidence of CAT scans. And I would like to also emphasize I see the ctDNA as frequently as being used in clinical trials as clearance. We are learning more and more ctDNA temporary clearance or reduction may not necessarily correlate always with survival outcomes. And we are learning that also the treatment, even modest activity, can suppress ctDNA secretion. So therefore, I think it's still a learning experience for us, and it shouldn't be a definitive tool in our box to make decision. Rather, it can give us an idea in clinical practice, but also the research.
Thank you. The next question is, does the percentage of cfDNA of specific biomarker make a difference in determining treatment, i.e. 0.2% versus 40% KRAS G13D in Guardant Infinity blood test?
Yes, very important question, and thank you for asking that, and highly relevant because I've seen that happening in real world as well pretty often. Some patients, when I see in my clinic, that comes with liquid biopsies, and this mutation allele frequency really matters because that we will not be we have to make sure we are really not targeting subclones that may be not relevant to progression of disease. So in that case, what I generally look overall cell-free DNA load in the blood. Let's say the founder mutation, just giving an example, P53 is 38%, and there is only 1% of KRAS mutation in the blood. That oftentimes happens when we give to our patients with EGFR blockade. We often see either KRAS or BRAF mutation emerging as a subclone, and they may disappear. So targeting 1% over 38%, knowing the rest of them probably don't have that mutation, may be important. So therefore, most of the trials that utilize ctDNA, such as the studies from the rechallenge, from EGFR rechallenge trials, such as KRONOS trial, they always look for ratio of that mutation into the total cell-free DNA, cancer DNA. So therefore, it is important and it's highly relevant. It could be we call it subclonal event. Maybe some small amount of cancer may have that mutation, and targeting that may not yield therapeutic efficacy because obviously the majority of the tumor are not going to benefit, not going to respond that therapeutic because they don't have that mutation.
Thank you. If you have been on sotorasib, can you then go on adagrasib after progression?
Yes, it's a question. We don't have an answer for that. Yeah, I think first thing I would do in that case to discuss with oncologists whether liquid biopsy can be done and see what happens since then. We have similar experiences, challenges, re-challenge therapies, I would say, because this is, in other words, we are re-challenging with another KRAS G12C inhibitor. We had similar intent and work in GI field with HER2, and I know in gastric field they did, and we did also in colon with EGFR re-challenge, those patients who progress on EGFR if they have RAS wild type disease were re-challenged, and we've seen some responses. That being said, we don't have that one in for KRAS G12C world yet. I know though there are some of pan-KRAS inhibitor and pan-RAS inhibitor that are in development to allow prior KRAS G12C. So if there's a trial that is available with pan-KRAS inhibitors, that may be actually more relevant and more meaningful than trying another G12C inhibitor. Outside of that, it will be just experimental, and I don't have evidence to say it will work.
Thank you.
Mhm.
So our next question is, understanding a lot of things are coming, but what should patients, for example, that are MSS G12D with no response to standard treatment options, as we know, FOLFIRINOX, FOLFIRI, what would you recommend for treatment options today?
Is this referring as a frontline therapy or option as we know, feel free to do for options today. If this is referring frontline therapy, obviously for G12D, we don't have available FDA labeled molecule or drug to use in daily practice. But again, as I mentioned, there are drug development that are pretty, I think G12D is one of the most drug developed molecule in development, I should say. And any of those trials will be I think, meaningful in a refractory setting, in chemo refractory setting. In terms of frontline, whether starting with FOLFIRINOX versus FOLFOX versus FOLFIRI, I think it's a discussion. I think for patients who are fit and who are interested in aggressive approaches, understanding 3-drug regimen is going to have more side effects than 2-drug regimen. It's certainly reasonable to consider 3-drug regimen based on the study that we have from the Europe, which is called TRIBE trial. In that study, the most benefit with 3-drug regimen was seen among patients with the BRAF mutations because unfortunately, they have real aggressive disease, and using all the drug available in upfront helps to control the cancer more readily. Thankfully, KRAS mutation are not as challenging as BRAF mutation. But that being said, for a patient who wants aggressive therapy, certainly triplet regimen is reasonable based on the overall slight improvement. It wasn't proven, but there was slight, I think, slight benefit, I should say, TRIBE in this trial with overall survival. So therefore, practice pattern hasn't switched to triplet as for all. Rather, it is more a discussion for each individual patient. And those who wants to be more aggressive upfront, certainly reasonable to consider FOLFIRINOX or FOLFOXIRI, or those patients who wants to focus on more quality of life and less aggressive approach, then doublet regimens are also reasonable.
Thank you. What KRAS trials are you part of, and are you finding there is a lot of patient interest? Are there limited slots?
Yeah. So yeah, very important question. There are we do have our trials at UPMC, and some of them are active and running. G12D trial for lead drug is just activated. It's still for at those escalations level, which means we are still trying to find the right dose to be tested in expansion course, also in phase 2. And the question regarding limited slots, it's a very big problem, which is why I'm trying to advocate that we should open in more institutions. And obviously there are challenges due to opening multiple trials at the same time and due to competing. But I think for KRAS trials, that should be an exception because there's huge unmet need, and we have a lot of patients with KRAS mutation in colon, in pancreatic cancer, obviously. And finding in those escalation slots is a big problem because you have to fill certain slots and see the safety before you move into efficacy in the next dose. And until then, they don't open slots like the randomized trial will obviously have a lot more available slots, unlike the early phase trials. So early phase trials do have that challenge. Some of the molecules like RMC 6236 are moving along in phase 2, but they are in pancreatic cancer now. Then obviously for that randomized phase, a lot easier because dose is defined and first come, first serve, versus here, unfortunately, when there's a dose escalation trial happening, then you have to wait that fill those, make sure they are safe before moving into the next dose. And then we have also pan-KRAS inhibitor of the Lilly company. It's not active yet. We are trying to activate the study.
Thank you. The next question is, if a stage 4 patient has progressed on first line, is enrolling in a clinical trial a good option, e.g., a targeted trial in combination with an EGFR?
So I think especially if there is strong biological reasoning, and especially as long as the patient has understanding there is a standard of care approach is available, yes. And I think that happened with the BRAF targeting. When we look the development of BRAF, Beacon doublet has been tested in second line plus, although it could have been just FOLFOX, FOLFIRI, and third line. I think it was smart. I think it was right thing to do because, especially for the BRAF, because it's a biological challenging disease and there are patients who can't make it in the third line. But KRAS is obviously biologically less aggressive, thanks to God. And nonetheless, I think as long as there's a strong biological reasoning and there is obvious engagement of the patient in terms of understanding risk and benefits, and especially if there's early signals that molecule is active, certainly can consider going in a trial where this opportunity may be available. And I think the reason I'm saying that, especially if there's biological reasoning, finding available slots in those trials may be challenging. And if the opportunity is there, trying to get maximum benefit from those agents that has some signals, and then having the second line drug, which will be available anyway, using in other time is certainly makes sense. But again, I think there has to be some good reasoning for that.
Thank you. And I have a question on, are there any trials for KRAS 12V?
So good question. I don't think there is, to my knowledge, I have to emphasize that because now this whole thing is expanding so rapidly. Maybe there's some drug hidden somewhere in animal models that I don't know. Not specifically V, but the pan-KRAS inhibitor and pan-RAS inhibitors supposedly have an activity on V. I know the Lilly drug pan-KRAS do include V mutation. I'm pretty confident on that because I was looking at a few days ago. So that pan-KRAS inhibitors covers the one with the Lilly. I know they cover, but I can't say for everything. Although some of the pan-KRAS inhibitors supposedly inhibiting all KRAS mutation, they may not be, but I know that the Lilly drugs do cover G12V mutation. I don't think there's allele specific molecule for G12V mutation itself, though.
Thank you so much.
My
I
pleasure.
think those are all the questions that I see. And I just wanted to see if you have any parting words for us, anything to say to the patients or the Colontown community about KRAS, or anything you think as far as with regard to what they're doing with their oncologists or questions they might ask. No pressure, but
No worries.
anything, any words of wisdom for this community, anything you'd like to say in that regard.
I think, to be honest, not individual level, I think at patient advocacy level, there's unmet need work for Colontown, and including I'm part of this I consider myself, because my own cousin had colon cancer age of 26. So colon cancer is dear to my heart. And I think there's significant unmet need for advocacy, for drug development. And I was trying to really put headlines and do on with large letters, trying to make sure I think the message is passed that we really need to make it clear to industry that colorectal cancer has specific characteristics, and that has to be implemented early because that's impacting their evolution, evolution. They're gonna continue to see more activity with monotherapy for other tumors, and they're gonna try to prioritize other tumors just because they see more signal with monotherapies. And unless they start using anti-EGFR in very early, even maybe at dose escalation level, this pattern is not going to change. So we'll have to really keep pushing and pushing and pushing the industry to make sure they understand we really have a different type of disease. We really need to make sure we are not ignoring the fact that we're not going to see good responses in colon cancer unless we use anti-EGFR early in the course. And this shouldn't delay drug development for patient with colon cancer.
Thank you so much for that. I really appreciate it. And a couple people have said thank you so much for your advocacy. So just know that your work is very appreciated in our community, by all of us, but especially, of course, by those in the KRAS community. So thank you so much for being here with us tonight and for sharing this with us. Thank you to all the patients and families that joined us live. We really appreciate your time, and thank you all for being here, and have a great night.
Thank you. It's been an honor. Have a wonderful day.
Thank you. Good night.
Bye-bye.